Hi, my name is Ruben, and today we're going to be talking about and demonstrating proning techniques to be done in the ICU. Prone positioning involves strategically moving patients to improve ventilation of the lower portion of the lungs and increase oxygenation. Specific for ARDS patients. ARDS stands for Acute Respiratory Distress Syndrome. Some more information about ARDS. Mortality ranges from 27% to 60% depending on severity. Proning is the frontline therapy for patients with ARDS.
Hello, I'm Bobby. I'm a respiratory therapist, and when we put patients into supine position, the abdominal contents, ventral portions of the lungs, and the heart put additional pressure on the lungs that reduces the alveolar expansion and worsens VQ mismatch. By putting them in a prone position, we are improving lung expansion, improving lung volumes, allowing oxygen to reach the portions of the lungs with the highest blood flow.
It has been shown that proning decreases mortality, decreases ventilator-induced lung injury, and improves lung ventilation and perfusion matching and oxygenation. Proning, among other strategies, may be indicated for dealing with ARDS patients. The inclusion criteria are severe acute respiratory distress syndrome, defined as a PaO2 to FiO2 ratio of less than 150, FiO2 greater than 60%, PEEP needs of greater than 5, tidal volumes of 6 mLs per kilo of predicted body weight. There are many contraindications for proning patients. The intracranial pressure of greater than 30, cerebral perfusion pressure of less than 60, massive hemoptysis, tracheal surgery or sternotomy, serious facial trauma or facial surgery, abdominal surgery and or open abdomen, DVT treated for less than 2 days, cardiac pacemaker inserted in the last 2 days, an unstable spine, femur or pelvic fractures, MAP less than 65, pregnancy, single anterior chest tube with air leaks, post-lung transplant, and burns greater than 20% of the body, underlying disease with life expectancy less than 1 year, and or opposition from next of kin. The CCRN indicates that since the COVID-19 pandemic, awake prone positioning has been utilized as a treatment option for non-intubated patients to improve oxygenation and help prevent the need for mechanical ventilation. So this is also an option up on the floors or in the ICU for patients who are not intubated. However, we won't be focusing on that today. All proning is supposed to be done between 8 a.m. and 5 p.m. The reason is in order to have as many resources as possible available. Now that's not always possible, and any of the exceptions that are part of the policy would have to get a doctor's order in order to facilitate that. Consent should be obtained whenever possible. Normally the patient will be too sick and sedated to get a consent. However, consent needs to be received from the family, and if no family is involved, the two doctors have to indicate that it is medically necessary. You need to have an order in place. The patients are properly sedated. Doctors normally order sedation or ROS -3 to -4. Based on our policy, a ROS of -5. As well, neuromuscular blockade. We got to establish access, Artline, central venous catheter, Foley catheter at the very least. The preferred method of feeding with proning is using tube feeding, specifically a post-pyloric feeding tube, one that goes past into the duodenum, and so less of a chance of gastric reflux. For example, here at Watsonville Hospital, we use the KO feed. If that isn't done, then doctor's order has to be obtained, normal checks on residuals to make sure that the patient is tolerating. You want to gather a staff of 3 to 4 nurses, a PT, and at least one respiratory therapist to be available for 20 minutes. If manual proning, you want to gather 3 pillows, 2 flat sheets, 3 pads. These are the Chuck's pads, some extra EKG leads, an ETT holder with extra ventilator circuit, including suction catheter, a foam pillow for the head, oral suctioning, ETT suctioning, and an emergency airway cart outside the room. You're going to want to remove, at least according to our policy, remove the ETT commercial securement device and secure it with a cloth tape unless ordered otherwise. Pre-oxygenate with 100% FiO2. The RN is to stop the tube feeding prior to proning, cap unnecessary lines, clean the patient, take care of any wound care needs, lubricate the eyes, and remove the EKG leads from the front of the patient. And then the doctor is going to make sure that the patient is sedated and or paralyzed as necessary. Based on our policy, an intensivist is supposed to be present during the proning and is supposed to be standing at the head of the bed, responsible for maintaining the patient's airway. It is the nurse's duty to make sure to get an order from the doctor that it's okay to prone the patient without a doctor being present. Next, you're going to want to prepare all invasive tubing and lines in anticipation of proning. Assure sufficient tubing length. You're going to want to relocate all drainage bags to one side of the bed. And you're going to want to move the Foley catheter and chest tube drains to between the patient legs. In anticipation of proning, once again, you're going to want to relocate the EKG leads to the lateral sides of the patient's shoulders and flanks. Position 2 staff members, RN, PT, or OT, on each side of the patient's bed with a minimum of 1 RN on each side. The intensivist will be at the head of the bed. If there's an order for proning without the intensivist being there, the RT will take care of the securement of the ET tube and being at the head of the bed during proning. You're going to want to remove the head of the bed for positioning. The RT is to prepare the ET tube and the suctioning equipment. RN confirms all central line catheters, art lines, and large bore peripheral catheters are firmly secured. Remove pressure transducer from the holder and place it next to the patient in the bed. We're going to make sure that all of our lines are secured. We have the RT checking the ET tube, and then we're going to check the IV tube. If we have an art line, we're going to make sure that the art line is secure. We're going to put the transducer and the pressure bag in the bed. Foley catheter, we're going to make sure we're going to put the bag in the bed, put it between the legs. Okay. Place the bed in a flattened position. Place a new flat sheet under the patient. Hold the patient to the side of the bed farthest from the ventilator. 1, 2, 3. Turning the patient to 45 degrees. Okay, and we're going to bring it up to 45 degrees, like that, just like that. Okay, let's hold it right there. Everybody stops for a safety check, make sure all the lines and tubes are still secure. So all lines and tubes looking okay?
Yeah.
Okay, turn patient to 90 degrees. Gonna apply EKG pads and leads to the patient's back at this point. And you're gonna remove all of the anterior chest leads. And then we return the patient to the supine position. At this point, you get 3 pillows, 1 across the chest, 1 across the hips, 1 pillow across the shins. You're going to get foam padding, optifoams, and you secure all the bony prominences, including on the face and cheeks. Next, we're going to place another flat sheet over the patient up to the neck, leaving the head exposed. And we're going to go ahead and do the burrito method. Show them, Jeff. So right now you have a sheet underneath and you have a sheet on top, and you're going to bunch it together on each side of the patient in order to secure them snugly. Okay, we're going to bring it 90 degrees. We're going to make sure everything's in place and nothing's dislodged. And then we're going to go ahead and prone. We have the foam.
Yeah, we got it.
Cool. We're going to slide the patient away from the ventilator towards the far end of the bed. Roll the patient to 90 degrees. Okay, count of 3. 1, 2, 3. 90 degrees. Make sure everything is secure and looking good. Everything's good. IV is good. Tubing.
Yeah, totally good.
TT. RT is to suction the airway, mouth, and nasal passages if necessary. And let's go ahead and prone. Reposition the patient in the center of the bed. Okay, let's reposition in the middle. All right, And lift up the patient. And the foam face protector. Repositioning of the head is to occur every 2 hours. Slide the patient towards the head of the bed until the head is off the bed. 1, 2, 3. RT will rotate patient's head to the opposite side while supporting the ET tube, and then slide the patient back down in the bed, back down, and then lift up the shoulders. Positioning of the arms for patient comfort is in the swimmer position, so one arm up, one arm down, and that is to alternate with the repositioning of the head as well. RT is to auscultate the chest every 2 hours, along with the movements, in order to verify that the ETT is not migrated into the right main stem. They're going to assess tidal volumes and minute ventilations. RN is going to ensure all the tubing and lines are free from compression on skin and bony prominences, and reassess all tubing and line connections. We're going to tilt then the patient into a reverse Trendelenburg position of between 10 and 20 degrees. At that point, document a complete and thorough skin assessment every shift. Feet are to be maintained in dorsiflexion. Shoulders are to be maintained in a relaxed position and to avoid any kind of shrugging. Foley tubing placed between the patient's legs and drainage bag hanging on the foot of the bed. Consider pressure relieving heel boots. As far as documentation is concerned, RNs are to document per the ICU protocol. RTs specifically document on the respiratory flow sheet the times that the patient is turned to the prone position and back to supine. Note all patient responses to turning and any other physiological changes observed. Reportable conditions would be any major changes or any instability. Emergency situations would be a dislodgement of the ET tube. Go ahead and call a code blue. And or cardiac arrest. Go ahead and call code blue. Ventilator strategies. Continue current lung protective strategy with volume assist control of 6 mL per kilogram of predicted body weight. The idea is lung protective ventilation methods is high PEEP and low volume. And that's how we treat for ARDS. Sedation is to be ROS of -4, -5, and duration is 16 hours a day as tolerated. When to stop proning is when in a supine position, improvement if PaO2 to FiO2 ratio is less than 150, FiO2 requirements are less than 60%, and PEEP requirements are less than 10 centimeters. Well done.